Chronic Limb-Threatening Ischemia, or CLTI, is the most severe manifestation of peripheral artery disease. It occurs when arterial blood flow to the lower extremities is critically restricted, resulting in ischemic foot pain at rest, non-healing ulcerations, or gangrene. Without rapid revascularization to restore blood flow, patients face extreme stakes. Within a single year of diagnosis, roughly 25% of these individuals will require a major limb amputation. Over the last decade, clinical practice has increasingly defaulted to an endovascular-first strategy, favoring minimally invasive catheter-based interventions over traditional open surgical bypass. This shift toward endovascular procedures occurred without definitive randomized clinical data comparing the two strategies in patients who are suitable candidates for both. To address this gap in the data, researchers designed the BEST-CLI trial. The central question: when a patient has anatomy that allows for either surgical bypass or endovascular therapy, which intervention actually yields better long-term limb outcomes? BEST-CLI was an international, prospective, randomized superiority trial enrolling 1,830 patients with CLTI. The investigators made a critical design choice. Before randomization, every patient underwent duplex ultrasonography to map their leg veins. The trial was then split based entirely on the availability of a viable autogenous conduit. Patients were funneled into two parallel cohorts based on vein quality. Cohort 1 included 1,434 patients with an adequate great saphenous vein for surgical bypass. Cohort 2 consisted of 396 patients lacking an adequate saphenous vein, requiring an alternative conduit. Within each cohort, patients were stratified by clinical severity, such as rest pain versus tissue loss, and then randomized to receive either surgery or endovascular therapy. Baseline characteristics were well balanced between the two treatment groups in both cohorts. By physically separating the trial into these two parallel arms, BEST-CLI moved the discussion away from a generic debate between surgery and endovascular therapy, focusing instead on patient-specific conduit availability. To evaluate the interventions, the researchers tracked a primary composite outcome: the incidence of a major adverse limb event, or MAIL, combined with death. This graphic breaks down the primary endpoint. A major adverse limb event specifically consists of an above-ankle amputation of the index limb or a major reintervention, such as a new bypass graft, graft revision, thrombectomy, or thrombolysis. For the patients in Cohort 1 who had an optimal saphenous vein, the results were definitive. After a 2.7-year follow-up, a primary outcome event occurred in 42.6% of the surgical group, compared to 57.4% in the endovascular group. This chart plots the primary outcome over time. Notice the widening divergence between the lower solid line for surgery and the upper dotted line for endovascular therapy. A hazard ratio of 0.68 and p-value under 0.001 represents a highly significant advantage for surgery. Table 2 reveals what drove this difference. Major reinterventions were required in 23.5% of the endovascular group, compared to only 9.2% of the surgical group. Furthermore, the above-ankle amputation rate dropped from 14.9% to 10.4% for those undergoing surgery. There were trade-offs in the immediate procedural metrics. The initial index procedure had a higher technical success rate in the surgical group, 98% versus 85%. But surgical patients required longer median hospital stays. For patients with a high-quality, great saphenous vein, an initial surgical bypass yields superior long-term limb salvage and drastically reduces the need for major interventions. We now have to examine Cohort 2, the patients who required an alternative prosthetic or autogenous conduit because they lacked an adequate saphenous vein. This chart plots Cohort 2 primary outcomes over a 1.6-year follow-up. The event curves overlap closely, with 42.8% in the surgical group and 47.7% in the endovascular group. A p-value of 0.12 indicates no statistically significant difference between approaches. Although time to major reintervention favored the surgical group, the overall clinical efficacy for limb events and survival was essentially equivalent between the two modalities. Beyond limb salvage, the investigators also tracked the systemic safety profiles of these procedures across both patient cohorts. This bar chart displays the major adverse cardiovascular events. Whether looking at myocardial infarction, stroke, or perioperative death, the incidence rates were remarkably similar across both treatment groups and both cohorts. There has been a historical assumption in clinical practice that open surgery is inherently more dangerous for frail patients with peripheral artery disease. The trial data shows that assumption is incorrect in appropriately selected patients. For patients lacking an adequate saphenous vein, the data proves both surgical and endovascular interventions offer comparable, low morbidity safety and efficacy profiles. To apply the BEST-CLI results to daily practice, we have to evaluate the trial's design limitations and the external factors that influence the data. The trial utilized a pragmatic, open-label design. Patient eligibility was determined locally by teams believing there was true clinical equipoise between the two treatments, which inherently introduces selection bias. There was also a high degree of procedural heterogeneity. Interventionalists and surgeons were allowed to choose their preferred techniques, and there were no standardized trial-wide protocols dictating the timing or method of reinterventions. Structurally, the trial was terminated early due to funding constraints. While investigators secured supplemental funds to ensure a full follow-up timeline for Cohort 1, this early halt left Cohort 2 underpowered. External events also played a role. A highly publicized meta-analysis raised concerns about a mortality risk associated with paclitaxel-coated balloons and stents. These devices are known to reduce the need for reintervention in certain arteries. The sudden safety concern likely suppressed their use in the endovascular arm of the trial, potentially skewing reintervention rates. While these variables do introduce noise into the data, they also reflect the actual and standardized reality of modern clinical practice. They provide context, but they do not invalidate the robust hazard ratios observed in the primary cohort. The takeaway from BEST-CLI is not an argument for performing bypass surgery on everyone. Endovascular therapy remains a vital, highly effective tool for limb preservation. Instead, these findings establish a data-driven framework for multidisciplinary teams, or MDTs, to evaluate and treat patients presenting with CLTI. First, teams assess surgical fitness and perform an ultrasound mapping to check for an adequate, single-segment great saphenous vein. Then, the team weighs secondary variables, the quality of distal anatomical targets, ischemic tissue loss severity, and patient values regarding recovery time versus procedural durability. The evidence no longer supports a dogmatic, universal endovascular-first strategy for every patient. If a patient is a surgical candidate with an adequate saphenous vein, bypass surgery offers statistically superior protection against major limb events and amputation. Conversely, if the patient requires an alternative conduit, true clinical equipoise exists, and the treatment approach must be highly individualized. Integrating anatomical realities, conduit availability, and patient goals through rigorous multidisciplinary collaboration is the incontrovertible gold standard for treating chronic limb-threatening ischemia.